Thanks very much, everyone, and good morning. My apologies for being a little bit delayed getting here. First of all, I want to welcome you all and thank you very much for attending here today. Really wanted to take this opportunity, in particular, just to have a kind of a recap of what's happening or what's been happening in the last year or so since we last had this event. Maybe pick out some of the areas where I think we've made some good progress, and at the same time acknowledge some of the areas where we haven't made the kind of progress that we had hoped to this time last year, but by no means are giving up on anything at all. You'll recall that what's being done now in health is really focused around 5 major themes, the first of which being Healthy Ireland, the government's cross-government, cross-society efforts to improve our health as individuals and improve the health of the nation for all the reasons that I think are obvious. Apart from the benefits to us as individuals in being healthier, I don't think we'll ever get on top of health budgets or demand in healthcare until we deal with some of those major public health issues. Improving patient outcomes and safety, things around access, waiting times, some other issues like that. Crucially, investment in infrastructure and ICT. Fourthly, universal healthcare, extending access to healthcare to more people, not having to pay fees or reduce fees altogether. And then also the whole health reform programme, which I think some people think isn't happening. It is. A lot is happening, just maybe not exactly what was intended this time 4 years ago. Healthy Ireland, as you know, touches a number of different themes. On alcohol, we will publish the public health alcohol bill in the next couple of weeks. Had hoped to have it done before the summer. We ran into some issues around what had to be in primary legislation and what didn't, but I'd hoped to bring that bill to Cabinet in September, October, publish it then. And that involves a few key areas, as you know, minimum unit pricing, and we had a decision from the Advocate General, or an opinion from the Advocate General in Europe yesterday, saying that minimum unit pricing was not contrary to European law, but it was incumbent on governments to prove that what was being achieved by minimum unit pricing could not be achieved by other measures, for example, excise or taxation. We're confident we can do that, because the reason why excise and taxation doesn't necessarily work is that there's nothing preventing retailers from selling below the cost of excise. You could put €5 excise on something that doesn't stop the retailer selling it for 4 as a loss leader. So we're confident that we can actually make that case and introduce that. The other measures, of course, are structural separation in stores so that alcohol is not sold as a normal product anymore. It's not just there behind the counter or being sold alongside the vegetables and crisps. It's going to be in a separate area like it used to be in the past. Then particularly labelling of alcohol and restrictions on advertising, and those restrictions now will be in primary legislation, particularly things like watersheds, what kind of advertising can be used, and what's going to be particularly the case there, and of particular importance, I think, is that advertising will be restricted to advertising the actual product and the content of the product and how it's made and what's in it and so on, not how it's going to make you good at sport or how it's going to make you able to play a musical instrument or be a really trendy person, like such in the Heineken ads, who manages to get through the whole city, not making a fool of himself, even taking huge of alcohol on board. The Healthy Ireland survey, we'd hope to be able to have publish the initial results of that in the next couple of weeks, and that's the first survey of Ireland's health as a nation really done since lawn back in 2007, and we need to repeat that every year because what you don't measure you can't improve, and we intend to do that regularly. We've already published, under the direction and guidance of Minister Lynch, the new suicide strategy, which you'll know about. We'd hope to have the new obesity policy published before the end of the year, and that's going to require really a series of actions. The more and more we've looked at obesity as a problem, there really aren't going to be any magic bullet solutions or 4 things that are going to solve everything. It's going to require a programme of change, some legislative, some involving education, some involving changes to our environment. Ultimately, when it comes to health, I think personal responsibility has to come first. People are responsible for their own health. but the government can play a helping role in changing the environment in which we live to help people to make the right decisions. And we do live in Ireland, in particular, in a very obesogenic environment where coming at us all the time are those high fat, high sugar, high calorie foods. And there are things that we can do as a government to assist people to make the right decisions. Smoking, you'll know about already. Smoking prevalence in Ireland has gone down from about 40% to under 20%, which is an enormous success and a real guide as to what we can do in other areas like alcohol and obesity. The next major things there, for example, will be around licensing and also plain packaging, which is more or less in the courts now, but something we're committed to. I threw in the sunbeds there because there's lots of other things going on in public health that you can forget about, but we have brought in new rules around sunbeds to reduce the prevalence of melanoma in Ireland, which has been rising considerably in recent years. And as you know, there's a ban now on children using sunbeds, for example, and that's in force. There'll also be the National Physical Activity Plan, which is linked, of course, to health, and that's almost ready to go to Cabinet. And the same applies to the new sexual health strategy. We have seen a worrying increase in STIs and HIV in the last couple of years, and we need to kind of turn the tide on that again, and that's going to be important. Now, inevitably, as is always the case in health, as we actually increase testing, we do intend to increase testing, things like rapid testing for HIV and encouraging more people to get tested. Once you do that, we're actually going to inevitably see an increase in the prevalence yet again, because if more people get tested, more people are going to be detected. But that's necessary, I think, in the initial step. What's particularly the case, as you know, with HIV, is HIV is generally passed on by those who are recently infected, have a high viral load, but don't know they're infected. And they go around infecting lots of other people until they're diagnosed. When people actually are diagnosed and are on treatment, it becomes quite hard for them to pass on the infection because their viral load is quite low. And that's really why it's so important to diagnose people. And we're seeing a particular trend of the age of diagnosis falling and younger people being diagnosed now, which is particularly worrying. There's a feeling among a lot of younger people in their 20s that HIV is a disease that people used to get, or is a disease for people in their 40s and 50s. That is now totally not the case. The age of diagnosis, initial diagnosis, falling to the high 20s, early 30s, which means people are getting infected in their mid-20s, which is kind of back to where we were in the early 80s all over again, and kind of shows why we need sustained action in that area. On patient outcomes, we're struggling with the waiting lists and waiting times, as you know. The key focus has been on targeting long waiters. At the moment, people who are waiting more than 18 months for an appointment, and we're moving to those waiting between 15 and 18 months for an appointment now. That's an appointment in a hospital, whether it's outpatients or a day case procedure or a surgical procedure. Where necessary, the private sector is being used. We prefer to use the public sector if we can, but sometimes it's just necessary to use the private sector and to outsource patients. And we're seeing some good results in that. We are coming up against some difficulties. There are some super specialties where no matter what we do or no matter what amount of money we have, there just isn't the capacity or the surgeons or the specialists available to get on top of things. And in some cases, for example, scoliosis operations for children, we're using hospitals overseas in London in order to tackle the long waiters there, which is far from ideal, but is kind of what we have to do. Waiting lists are funny things. Every time you set up a new service, there's a new waiting list for it. And often when you hear the figures quoted in the media, what's not said is that many of the people may be waiting 2 weeks, 3 weeks, less than 3 months. That global figure that gets thrown out there is really anyone who just doesn't have an appointment time yet, and they're not necessarily waiting long periods of time. So we're focusing not so much on that big figure of how many people are waiting any amount of time, but rather those who are waiting extraordinary long periods of time, such as more than a year, and particularly more than 15 or 18 months, which is nothing to be proud of. Other countries have it down around 3 or 4 months, but at least it's what we're focusing on. On tackling emergency department overcrowding, has been a real difficulty. If you take from where we are here compared to this time last year, there are 2,500 more staff in our acute hospitals. The number of delayed discharges, patients in a hospital bed awaiting a long-term care placement or awaiting home care packages, because of the additional investment in those areas, the number of delayed discharges is down from 850 to 500 and something now. It's a 6 or 7 year low. There are additional community beds open all over the place. Minister Lynch officially opened Mount Carmel yesterday, and there's about 200 more community beds open around the place, from the Phoenix Park to the Royal Donnybrook to Mount Carmel to Moore Hall. Despite all of that, hospital overcrowding is still worse than it was this time last year, which creates an enormous dilemma for you, because when you listen to the advice that you're given from all the various interests that we need more staff and more beds, and you actually do all that and it doesn't work, you do start to wonder what you need to do. And the reason why hospital overcrowding is so difficult to resolve is because there's so many different factors at play, and they're not the same in each hospital. They vary very much from hospital to hospital, but we're not giving up, and we do have plans in place to provide additional capacity, particularly acute hospital beds within the hospitals between now and Christmas, and to do some other things that will hopefully alleviate that problem. The cost of medicines you'll know about, a lot being done to reduce the cost of medicines to the public, particularly with things like reference pricing. We published in the last year the first National Healthcare Quality Reporting System report, and that was publishing hospital by hospital figures such as length of stay, diabetes admissions, asthma admissions, cardiac deaths, stroke deaths, so we can actually start to compare from hospital to hospital different outcomes. And of course, if somebody is more likely to die in one hospital than the other, that does not mean that hospital is worse, but it does cause you to want to know why that is. And often you can find that it's for a very good reason. There's one hospital in Dublin where you're more likely to die of a heart attack than the other place, but that's because that hospital transfers the patients who can be treated to the Mater, and the ones they keep, of course, are the ones who are largely palliative. So it's important all those stats are treated properly. But we're going to publish that every year and expand it every year. It does immunisation rates by county, for example. Roscommon having the best immunisation rates, other places being much lower, and I think that'll help us to improve quality in the years to come. One thing that's really missing from that we'd hope to address in the next year or so is patient experience. We don't do enough surveys of what people's patient experience is, how they actually found the hospital that they're in, what they think of their GP, how they found the particular service that they encountered with, and we need to do that much better. And the Chief Medical Officer in HIQA have a plan now in place to do that now regularly and publish it regularly as to what the patient's view is of their experience in a particular service of the health service, because we rely so much on anecdote at the moment. The one or two people who maybe had a terrible experience, or the 10 or 11 who say it was great once they got in there, but we don't really know, and that's why we need to do that methodically and objectively in the future. On patient safety, I'm going to bring the heads of the Health Information and Patient Safety Bill to Cabinet in the next couple of weeks. That does a number of things. It's going to involve extending the remit of HIQA, allowing them to regulate home care, which is very important, extending their remit to areas such as private hospitals in certain circumstances, and there'll be quite a lot in that bill that I think is going to be very important. We have the National Clinical Effectiveness Guidelines, which you'll know about, and it's important now that they're monitored and implemented. Franz Fitzgerald will bring in the legislation to protect open disclosure. We'd hope to have that through before the Dáil is dissolved, and that we believe will enable clinicians and others to engage more in open disclosure and take away some of the fear that exists around offering apologies and giving full information. And of course, following the HIQA report on Portlaoise, there will be a patient advocacy service established before May next year. The other theme, of course, is infrastructure. The good news is that we now have the planning permission for the new National Forensic Mental Health Campus in Portrane. That will replace the facilities in Dundrum in the Central Mental Hospital there, and will involve additional facilities as well. And that planning permission now is through, It's been granted, and we'd hope construction to begin next year on that very important project, really replacing one of those Victorian facilities that we still have with something very new and state-of-the-art. And we've so much of that, as you know, in our health service, of very old buildings, very old infrastructure, people working out of Victorian, Edwardian, and even old workhouses all over the place. And we need a big capital program over the next number of years to change that. The planning application is now in for the new Children's Hospital, again replacing very old infrastructure in places like Temple Street, to a lesser extent Crumlin, with the new National Children's Hospital, the Specialist Centre on the campus of St James's, the largest teaching hospital in the state, and the satellite centres in Blanchardstown and Tala. All things going to plan, and planning permission being secured. Construction can begin next year. Have the satellite centres open in 2017 and the new hospital open in 2019 and fully commissioned by 2020. And that is now part of a statutory process with An Bord Pleanála. There will probably be oral hearings later in the year, and we'd hope that they'll come to a decision on that in January or February, if not sooner. We have a programme now as well to move the maternity hospitals, to co-locate them with adult hospitals, to ensure, first of all, that they have state-of-the-art infrastructure, which they don't currently have, but also co-locating them with adult hospitals for obvious reasons, so that if a woman needs to go to ICU, she can. She's not separated from her child. At the moment that happens, where the baby, of course, is in a totally different hospital, in a totally different campus. And also, if there are complicated pregnancies, to have the cardiologists, neurologists, immunologists, all the people who need to help out with those complicated pregnancies on the same campus. I think that'll really improve maternity care. We shouldn't, of course, forget that there's more to maternity than the 4 standalone maternity hospitals. That there's a maternity strategy being developed to map the future of maternity services across the country. The first one up is Holles Street, the National Maternity Hospital. There have been some difficulties, some logistical issues between Holles Street and St Vincent's, but that's now back on track, and it's still expected that the planning application for that will be lodged in December of this year, with a view to construction commencing next year. And we'll move on very quickly to putting in planning applications for the Rotunda to go to Blanchardstown, the Coombe to the St James's campus, and Limerick to move from St Munchin's across the river to the main campus at Duradoyle. There's a National Radiation Oncology Programme, which you'll know about, and also there's the primary care centres, about 1 a month now being built and opened, nearly 100 now in operation. Largely gone unnoticed, unfortunately, around the country, but where they're there, they really are high quality accommodation and are a big part of the future. So I think it would be an interesting place if by this time next year we have a new children's hospital, a new forensic mental health campus, and at least 1 new maternity hospital under construction. And that's a realistic possibility that can be the case. I think will be the case, in fact, by this time next year. On ICT, I'm not going to go on about that too much because Richard's going to speak later, but suffice to say that we have an enormous ICT challenge in healthcare. We're way behind other countries, we're way behind other sectors, and it's shocking really how far behind we are when you think about it. I often tell the story that there's 2, I don't eat pizza anymore because I'm trying to be healthy, but there's two Domino's pizzas in my constituency, one in Ongar and one in Carpenterstown. And when I ring up, they know immediately from my phone number exactly who I am, where I live, and what my favourite order is. And it doesn't matter whether it's Ongar or Carpenterstown. And yet we can't do that in healthcare. You know, people have different medical record numbers, different charts all over the place, and there's lots of inefficiencies there, and also lots of safety risks in that too. And I think there's a big job to upgrade our IT over the next couple of years. The intention, of course, is that the Children's Hospital will be paperless from day one, will be an IT hospital, and that's very important. We also want to make progress on the electronic patient record. What I'd like to see by the end of this decade or the start of the next one is that from the moment the patient gets into the back of the ambulance, the paramedic on his iPad can access the patient's medical records and information, know a bit about them, know what their ECG is supposed to look like, and have emailed all that information into the emergency department as the patient arrives. And that, I think, would be a big change. Most countries haven't managed to do that, by the way, but I think maybe we can. E-referral is very important too, and in fairness, in some areas where there has been good progress is labs and radiology. It is great to see NIMS up and running in so many hospitals where the X-rays, the CT scans, and the MRIs are all there electronically for doctors and staff to look at and analyse. I remember as a junior doctor having to run around the place trying to find X-rays and carry them around in big envelopes and sometimes find them down behind the back of a radiator or in the on-call room, or God knows where the X-rays used to end up. And I'm glad that's not as much the case as it used to be because of investment in IT, which is really important. On universal healthcare, I think there have been some really big steps in the last year or so. The under sixes, the fact that everyone under 6 is entitled to see their GP without paying fees, and also everyone over 70. That's nearly 300,000 people who don't have to pay their doctor today, who used to have to, and they are, of course, the youngest and oldest in society, those who need to see their GP the most. And that's only a start. Also making good progress on moving chronic disease more into primary care. The asthma cycle of care is there for the under 6s, just starting up around now. I think, in fact, patient registration begins next week on diabetes for type 2 diabetic patients who have a medical card or a doctor visit card, being able to have their diabetes managed in a structured way by their GP in the community, rather than having to go through these hospital clinics, which are a total zoo, and you probably see a different SHO every time you turn up to that clinic. It's much better for that to be dealt with in primary care, where you're going to see the GP or the practice nurse every time, and be properly monitored. And of course, there's all the measures that have been introduced to contain the cost of health insurance, to stop those double-digit increases in health insurance that we had for a number of years. And you'll know the kind of measures that were put in place on that in the year gone by, with lifetime community rating and so on. There's a reform project within the department, because the department has to really be the brains of the operation, and in some ways has been denuded in recent years. The number of civil servants, believe it or not, working in the Department of Health is about 300 and something. In transport, tourism and sport, I had nearly 500. It's not directly comparable, but it does say something in itself, that a government department that is responsible for 25% of the government's budget, 25% of what goes on, is actually pretty slim, because over the years everything was kind of handed over to the HSE and to regulators like HICWA and so on. And I'm not sure that's entirely been for the best, because it does mean that you have at the top of everything quite a small brain in many ways. And that's not a comment on the people who work in the Department of Health, just the reality of the fact that we have at its head a parent, essentially, to these monstrous children, and not necessarily the brains or tools to keep control of things. So Jim Breslin, Secretary General, is leading quite a big reform program within health, and is restructuring the top management team. We're going to have 2 Deputy Secretary Generals being appointed quite soon. One who's going to be responsible particularly for the whole area of performance and governance, holding the agencies to account, making sure they perform, and making sure that governance is sound. And then there'll be somebody who's responsible for policy and strategy. And of course, beneath them, you'll have the traditional areas like acute hospitals, primary care, and so on. But having those 2 new roles, I think, is going to be crucial. There'll also be a new Assistant Secretary General who'll be responsible for research, development, and health analytics, which again we just don't do enough of. We don't analyse the information in the way that we should, and those changes will take time to actually show any results, but they are happening, and I think they're going to be really important. That's much too hard to read, I think. That's kind of the bigger picture around health reform. But just starting from the left, you have really what's happening with the GPs and primary care. We're now into discussions on the new contract, which is the new contract, if you like, to replace the existing old GMS contract. At the moment, the talks are focusing particularly on the whole area of rural practice, which is a real difficult area at the moment in filling those posts. But it's going to move on to other things, like extending the role of GPs, to things like minor injuries, chronic care, out of hours, There's a particular module on urban deprived areas, which again it can be a black spot as much as the rural areas, but you don't hear about it as much. And all the different things that we want out of general practice in the future. And of course, the fee structure is going to be crucial to that as well. And those talks are underway at the moment, and we'd really like to have a new contract agreed in the first quarter of next year, ideally, and then phase it in and resource it over time, because I don't think we're going to get anywhere in health if we don't really expand primary care in a way that hasn't been done in the past. There's, I suppose, a couple things other there I've kind of thrown in there, the single waiting list and access arrangement. There's obviously issues around the consultant contract. I think in the way now that we charge private patients at public hospitals has more or less made a nonsense of the existing consultant contract, and we're going to need to do something there, I think, in the future and revise that. We're pushing ahead on the individual health identifiers. And we just delegated responsibility for that for the registers of the HSE at Cabinet last week, and that's happening much slower than I'd like it to, but I would anticipate that it will happen sooner rather than later, that we'll have individual health identifiers for everyone working in the health service, and more importantly for every patient, so that there is a dedicated health number, if you like, for PPS. There is a good reason why we're not using PPS, by the way, and but I won't go into that now. But we're very keen to make a reality of that project, and certainly getting the register up and running in the next couple of months or year. Activity-based funding, our money follows the patient. That's more advanced than people may think. The Health Pricing Office is established, trying to set prices for particular procedures, for lengths of stay and so on. And that's a project that I think is going to need a big boost in the year ahead to properly move the funding of hospitals away from block budgets to activity-based funding, where hospitals are paid for what they do rather than based on traditional block budgets. But there will be a transition period. It wouldn't be possible tomorrow to just cut 10 million off the least efficient hospital and add 10 million to the most efficient, because the ones who'd lose out there, of course, are the patients. But there will be a transition period, and I think of all the reforms in health, that's actually the one that will make the most difference, because if we can actually crack that nut of linking finance and funding to results and outcomes, we'll have a much better health service. And I think it's fair to say, and we'll all acknowledge, that we don't really get value for money in our health service. Our health spending is lower than it should be, but it's certainly not on the floor when you compare us with other European countries. We're kind of in the mid-range, but we don't get the kind of value for money that we should be getting from our health service, and that's something that really has to change. And it's very hard to argue for additional finance when it's so evident that we're not getting the results for what we do invest already. And then, of course, what has been established are the hospital groups, which you'll know about. Really want to put them on a statutory footing in the next 18 months, and also the community healthcare organisations, and they essentially become the providers. The hospital groups, the community healthcare organisations, and other bodies like the National Ambulance Service become the providers, and that allows us to achieve the purchaser-provider split, where what's left of the HSE, if you like, becomes the commissioning agency. It's not all figured out yet, but that's the broad vision, and a lot of it's happening. That's just a map of the hospital groups and the CHOs, the community health organisations, if people aren't familiar with them already. And they do exist, but they just need to be properly embedded and staffed and have the leadership that they need, and then put on a statutory footing. The hospital groups can be put on a statutory footing in the next 12 to 18 months. I think we probably should put the community healthcare organisations on a statutory footing as well, and maybe they should have their own boards too, and be proper providers, in some ways equal to the hospital groups, because of what they're going to do. And if you take the budgets of those CHOs put together, it'll be similar to the hospitals, if not more. And if we're serious about saying that primary care and community care and social care is as important as hospitals, I think we need to treat them similarly in all sorts of different ways. In terms of the areas where I think we actually are making good progress, dare I say it, just kind of starting at the top there with the additional frontline staff. There are an additional 2,384 people working in our hospitals than there was this time last year. They're not all managers, by the way. Most of them are frontline staff. We actually have about 3,000 or 4,000 fewer managers and administrators than there were 10 years ago. But there has been a significant increase, notwithstanding the problems with recruitment, which are very real. We are recruiting, and that's evidenced by the fact that there are so many more people working in our hospitals than this time last year. The under 6s and over 70s, which I've mentioned already. On health insurance, because of the carrot and stick measures brought in by government, there are 100,000 more people today who have health insurance than this time last year. Still below where it was before the economic crisis, but going in the right direction again. On delayed discharges, it peaked around 850 last November, December. It's now down around 550. So that's freed up 300 acute hospital beds every day, has been freed up because of the additional investment in the Fair Deal and the additional investment in the home care packages and home help. The Fair Deal waiting list was at one stage at about 16 weeks. That's down around 4, and actually for various periods of the summer was down around 2 weeks. So that's really ticking over very well and has freed up a lot of capacity in hospitals. But as I say, on the downside, hasn't had the impact on the hospitals that we'd hoped. We're still struggling in waiting times, which you'll know about, but we are committing an extra 50 million this year, and that's been signed off by Brendan Howlin already to allow us to spend about 50 million this year, really tackling those very long waiters. The ED overcrowding, as you know about, is an ongoing problem, but we're going to bring in some additional measures between now and the end of the year to try and free up and make more capacity available. We've the ongoing struggle with HICWA compliance, complying with the care standards for the disabled and older people, and also complying with the new infrastructural standards that are there for care homes for older people and for the disabled. But I think there's an important point that may be lost that is probably worth making about some of the problems that we have in disability centres and in older care centres. None of these problems can be new. You know, they must have been going on for decades. The difference now is that we have standards, we have independent regulation, we have inspections. The findings of those inspections are published for everyone to see, and now we at least have a system and a government in place that cares enough to actually do something about it. And I really think we need to make that point and explain that a little bit more. You know, before 2013, there was no independent regulation of disability centres, and once you bring it in, of course, it's going to expose all those kind of problems that must have been there forever. But now we need to act on them and improve the quality of care provided to older people and in those centres. And then also a huge and enormously expensive challenge to replace some of the very old ones with newer centres and new infrastructure. And Minister Lynch and I are working very hard with our government colleagues to try and secure additional finance in the new capital programme to speed up decongregation, to move more people out of disability centres into the community, and also to upgrade our existing elderly care centres. And when you go into them, it's an experience to visit them, and some of you have done that, and you'll often go into the older ones, the old workhouses, and you'll see people in, you know, rooms of 4, rooms of 6 and so on, and by and large they're actually quite happy with the care they get there, and very often their families are too. And you kind of leave somewhere like that and you say, you know, it isn't all that bad. You know, what's HICWA's problem? And then you go into one of the new ones that was built in the last 7 or 8 years, maybe somewhere like the new Phoenix Park community nursing units, which is on the grounds of St Mary's, and then you see what it's supposed to be like, and you kind of think to yourself, well, actually, this is where I'd like to go. I'd be happy enough to be here if I was 70 or 80 in my own room, in my own suite, and this is the kind of place I'd be happy for my mother or father to go into in the future if they needed to. And so often only when you see the new infrastructure that you realise how bad the old stuff is. And the same applies in the hospitals as well. It's when you wander through the Whitty building in the Mater, or the new critical care block in Limerick, and then you wander back into the old part of the hospital and you suddenly realise quite how bad some of that infrastructure is. But it's an enormous cost to upgrade all of this and replace it. and the idea that we can replace 200 years worth of infrastructure in 2 years or 3 years or even 10 is just not realistic. But we do need to have a capital program to do exactly that within not too long a period. And of course, we have the major challenge around financial control in the health service, which is a real difficulty. I thought I'd throw that slide up. That's from the Irish Fiscal Advisory Council did an analysis of health spending and sought to explain why health overruns so much so often. Didn't particularly give us any great insights, unfortunately. I kind of read it with great passion and enthusiasm when I was on holidays, and I thought, here's a 30-page report that is going to explain to me why health overruns and what we can do about it. And I read it, and 32 pages later, I was none the wiser as to what we were going to do. But it was a useful exercise for them to do nonetheless. But it just kind of gives you an idea of how health spending has gone in Ireland in the last couple of years. You can see back in 1994, which wasn't all that long ago, that was the John Bruton government, the last Rainbow Coalition. We were only spending a little over 2 billion on health, and now we spend 14 billion on health. So health spending in the last 20 years has increased sevenfold, and that's extraordinary if you think about it. And then it kind of makes you wonder, in 20 years' time, will we be spending 114 billion on health? I don't know. Who knows? And obviously that'll have a lot to do with inflation and so on, and even could we afford that? But you can see the health spending really did escalate very fast during the boom period, peaked around 2008, 2009. Then about 2 billion was cut out of health, actually by the previous government, and there where you see it flatlining there under the current government, despite our best efforts, actually never managed to reduce health spending. And it remained steady over the last couple of years, and now is starting to rise again, and rise very slowly. But that's the picture there, which you kind of see. We do, of course. I've no doubt at all that we do need to restore health spending in Ireland pretty much back to what it was in 2008, 2009, what it was 7 or 8 years ago. I don't think that's a huge amount of money really to spend. There'd be very few health services in countries that haven't been involved in a war that spend less than they did 7 years ago. And I do think it's a reasonable objective to try and bring staffing levels and spending levels back to where they were in 2008. What is not possible or reasonable is to think we can do it in 1 year or one budget in 6 weeks' time. So that's going to have to happen over a period of time, and I think over a period of years. And coupled to that, of course, is the fact that we need to make sure that we get better value for money and proper bang for our buck for the money that we invest in our health service. Ironically, during that period when health spending was falling and staff numbers were falling, so were waiting lists and trolley numbers. As health spending increases and staff numbers increase, waiting lists and trolley numbers are getting worse. So it's hard to see. There certainly is no direct correlation between spending and staff and outcomes. There may be an indirect one, that an equation that somebody else has to figure out. But it's pretty clear that we need to do much better with the budget that we have. And at 7.5%, 8% of GDP, or 10% of GNP, we're not wildly underspending compared to other European countries. We're in the middle range, but maybe aren't getting the outcomes or results that we should get. They're just the kind of overruns, health overrunning in pretty much every year now for the last 5 or 6 years. But we're not the only ones where it happens. You can see it happens with social protection as well. Not in recent years because unemployment is falling, but certainly during the recession itself, when unemployment was rising quite fast, social protection overspent big time. And I think sometimes that just reflects the way demand can hit you, whether you like it or not, and that does happen in health, happen in health as well. So I suppose looking forward, and what I'm hoping we can do today, during the sessions today and during the conversation today, is to think a little bit about the budget and what the priorities should be in the budget, which then leads, of course, to the National Service Plan. We're in quite a tight time frame there. The budget's only 5-6 weeks away. And in health, in many ways, we have two budgets. We have the first part of the budget where we try to get a budget, and then we've got the second part where we try to cobble together a decent service plan in the weeks after that. And we're certainly interested in people's perspectives as to what we should try to include in the National Service Plan. In reality, because of the overspend this year, most of which will reoccur next year, there's very few one-offs there. The capacity, I think, for new developments, for additional spending, is going to be very tight, even tighter than it was last year. Like so many things, you can create a very long wish list, and then you have to pick the 10% of that wish list or less that you can actually do in any given year, and that's kind of where we are. So there'll be a real need to prioritise there. And then also, I think, because even though the Dáil may be dissolved in the next 20 weeks, and it will be dissolved, the Dáil has to be dissolved within 23 weeks of today. So there's a very short period left in this Dáil. In health, we can't afford to think like that. We need to make sure that we're thinking medium term and long term. And we're very interested as well in people's perspectives on where we're going in the longer period. So that's really what I'm hoping to get from today, some input from you on what you believe should be the priorities for the budget and the service plan, bearing in mind that everything can't be a priority because then it's not a priority, what we can do further to improve access to healthcare and also improve outcomes from our healthcare, where we're going on structural reform, whether it's the right direction and what else can be done there, and then also particularly on modernising. I think there's two levels of reform. There's the structural reform that you do at a bureaucratic level, like hospital groups and community health organisations, but there's also a big modernisation reform that needs to happen at ward level and at community level. And I think that's the conversation we're going to have around IT is going to be very important, about integrated health. All those things are about the reform that needs to happen, I think, at patient-facing level, because as somebody who worked in the health service for 7 years and somebody who still knows a lot of people working in the health service, so much of these reforms that we talk about, whether it's health boards or health authorities or health executives or hospital groups or CHOs, people working on St. John's ward in St. James's, all that just passed them by. It's still the same job that they do in the same place. And what we need, I think, to focus on in modernisation a lot is the kind of reforms that actually impact in the pharmacy, in the general practice, and at ward level, and probably need to do a little bit more of that than we did in the past. So that's my introduction. Again, really glad that you're here today, and look forward to hearing from you as the day goes on. Thank you.